in Curitiba, Brazil, maintaining a close relationship with folks down there. Roberto has also has leadership roles with the ISN as well, and is the principal investigator for our CK-DOPPS study, bringing all sorts of enthusiasm and expertise to CK-DOPPS. So without further ado, I'll pass things over to Roberto.
Thanks so much, Bruce. I've been enjoying this presentation so much, but now it's time to move to our next section of the program, which will be presented by Dr. Elliot Tanner. So my friend Elliot is a nephrologist and a kidney health advocate and the CEO of an NGO called Kidney Health International. He's also a senior lecturer at the Kwame Nkrumah University in Ghana. He was the chair of the Young Nephrologist Committee of the ISN and is a very active member of the Education Working Group. Perhaps most importantly, he is the leader of the manuscript based on the results of the ISN DOPPS survey on the impact of the COVID-19 pandemic on dialysis services, with a particular focus on low and middle income countries. So now let's hear from Elliot.
Thank you very much for the invitation to have a presentation on behalf of the ISN DOPPS work that we did on COVID-19, the ISN DOPPS survey. So it's a COVID-19 pandemic identifies significant global inequities in hemodialysis care in low and middle income countries. My name is Elliot Tano, and I am a nephrologist in Ghana, and I'm happy to give this presentation in the next few minutes. So, yes. All right, so I have no disclosures, and indeed, by way of introduction, we all know COVID-19 pandemic has had devastating global impact on healthcare system, more especially in low and middle income countries. And indeed, it's all because of insufficient investment in healthcare, poor healthcare infrastructure, and then low-skilled labor, to name a few. Patients on HD have particularly have challenging issues, and they had reported mortalities of about 10 to 41%, basically. And indeed, all of this as a result of various factors that have been stipulated: advanced age, diabetes, hypertension, cardiovascular diseases, all these pre-morbid or comorbid conditions, impaired immune systems, and then basically in the HD unit, we believe that the poor social distancing also be a factor. What are their challenges? So it's actually, like I mentioned, a fragile health system in low and middle income countries, lack of diagnostic testing. So these are particularly had to do with COVID-19 itself, low staff numbers, which has been associated with physical and mental stress, and then the strict lockdown. Indeed, some of us realized the challenges patients and even staff had during the lockdown in terms of transport, and indeed the limited access to PPEs. And this is what we hope to survey to find out. Indeed, there has been guidelines that has been set by various organizations, the CDC, the EDTA, the United Kingdom, International Society of Nephrology, and the African Association of Nephrology also, which focus mainly on low and middle income countries. But then the point is that for you to have a successful implementation of guidelines, you actually need some resources to be available. So that was also challenging. Why? Because resources were not available. Because for successful implementation, you need the availability of resources, infrastructure. You need access to testing, indeed, and that has also been a major challenge. You need adequate PPEs for staff and then patients alike when they especially come to the HD units. And then the isolation rooms, basically for HD. So now you suspect a patient has COVID and all. I mean, how do you isolate the patient if you don't have the infrastructure to isolate such a patient? And then again, the availability of requisite human resource for optimum management of cases. Now, our research question was, has the COVID-19 pandemic disproportionately affected care in chronic dialysis patients in low middle income country settings? And what was our method? So ISN together with DOPPS came together to have this online survey to be able to answer one objective. And the objective was to describe the global inequities in kidney failure care as they relate to income status. And we use actually the World Bank classification. So what has been the journey so far? So we all know COVID-19 started in Wuhan, basically in 2019, December. We didn't think that in 3 months down the line, it would be declared in March as a pandemic. And the ISN, the initial survey was developed. So interestingly enough, DOPPS were doing their own thing, and ISN as of the time were doing our own thing. And it so happened that since we had people of the two, we came together to be able to develop a survey, because the survey was not just now for the DOPPS countries, but it had to be extended to the non-DOPPS countries. So the first stage was actually a stratified random sampling that was used basically in terms of the DOPPS methodology, where countries with greater than 40 HD units were actually asked to stratify in terms of the public and then private, in terms of geographical location. But in most countries that had less, or in some countries, or countries that had less than 40, they were actually asked to virtually select all of these countries. So what was the result like? So we sent out to about 113 countries, and indeed we had 43 only responding. That gave us a survey number of about 240, including that of the China DOPPS. So at stage 2 actually was thrown in, where a convenience sampling method was actually used, where we just sent out emails and then used the regional boards and all in terms of the ISN groups to be able to get a bit more in terms of the response. And we were able to get about extra 162 surveys from together 78 countries. So totaling, we had 412 responses from 78 countries. The distribution was basically about 4% from low-income countries, 27% from low-middle-income countries, 34 and 35 from the high-income and the upper-middle-income countries, respectively. The survey was actually divided basically into patient-level factors and then the staff-level factors. So the patient-level factors were mainly about diagnostic testing, interruption to hemodialysis delivery, restrictions to access to hemodialysis, ICU care, and mechanical ventilation, and then reported mortalities. For the staff level care, we were interested in, again, the diagnostic testing availability and a shortage of PPEs, training and guidance that some of these staff were getting, and the psychological support. So for the patient level factors, what are some of the things we found? So we clearly realized that there were unavailability or limited availability of diagnostic testing more in low and low middle income countries as compared to the high income and then the upper middle income countries, as you can see by the figure. Then for those for diagnostic testing, we also, for asymptomatic patients, realized that routine diagnostic testing was more commonly done for people in the high end. And then you realize that those in low and low middle income countries were really shortchanged. What about the turnaround time? And indeed, I can identify with turnaround time for patients when for testing for patients, because you've done a test, you are waiting for the response, and averagely was taking over 7 days to get it. And indeed, our survey also showed similar. So you realize that if you take, let's say, diagnostic testing for low and low middle income countries, majority indeed were 3 to 7 days. When you go to the high income countries, you realize that on the same day, they are getting response. And indeed, these were challenges that we faced during the time of the pandemic. Out-of-pocket payments, like you can see from the figure, was more in low and middle income countries. So the patients have to pay out of pocket to be tested. So what if the patient does not have money, they don't get the testing done, they don't show up for dialysis units, and probably they might portend to worse outcomes in terms of their management. And then the challenges in terms of transport, again, more challenges in low and low middle income countries as compared to the upper middle and then the high income countries. So this is actually one of the most important slides, which we realized that indeed those who had chronic kidney failure, who were on admission, who required mechanical ventilation, who required ICU admission, they were restricted because of their condition. And you realize that in low and low middle income countries, there were more restrictions. So if you look at ICU care, for instance, in blue, there were more restrictions in low and low middle income countries as compared to the upper and then the high income countries. If you take the deeper blue, which is those who were dialyzed whilst on admission, basically, again, the restrictions were more in the low and middle income countries, and so on and so forth, as you can see. Mortalities reported, so these were reported mortalities. These are not mortalities that we measured ourselves. So it's actually a rate, what do you call it, a limitation. So reported mortalities were such that those who reported the dying of about 50% of patients was actually about 30 in low and middle income countries as compared to 8, so in the high income countries. So in terms of staffing, the staff level problems were such that asymptomatic testing was basically for staff was less, and indeed this again was a problem. If you have a patient, you are exposed to a patient with COVID-19 who you are not too sure has it or does not have it, and you need to be tested, indeed that testing became actually a problem for you as a staff. And this was some of the things we experienced in our setting, where your hospital will tell you, okay, just go and stay at home for 2 weeks, and you just don't know what to expect, instead of probably being just tested to know what exactly was going on. So shortages of PPE was another big challenge, and indeed this was reflected also in our survey. Low and low income countries reported severe shortages of PPEs at the peak of the pandemic, and the use of PPEs beyond the manufacturer's shelf life again was more in low and low middle income countries as compared to the high income countries, as you can see. Paying out of pocket for PPEs indeed was such a big staff problem. So indeed, if you really wanted to use a PPE adequately, you needed to go and buy it because it was not available. And this, again, we can see in low and low middle income countries was such a big problem as compared to the high. This survey, part of the survey was only given to those with, what do you call it? Those with in the low and low middle income countries. And we realized that, again, the low income countries suffered less training, less guidance, less psychological support as compared to those in the low middle income countries. Indeed, in conclusion, we have noted that there are striking global inequities in COVID-19 management, in the diagnostic, infection prevention, and access to routine care. Higher apparent mortalities in patients with chronic HD in low and low income countries is likely multifactorial, like it's been said, reflecting the poor access to diagnosis and care of COVID-19, as well as greater disruption of their HD care. So then there's urgent action is required if we are able to bridge the gap in terms of these inequities, because it is very important that as we get along, we'll be able to get low and low middle income countries content. So thank you very much for the time, and I would appreciate your questions as they come through. On behalf of the ISN DOPPS survey, my name is Elliot. Thank you very much.
Well, thanks so much, Elliot, and you know, congratulations for the